Welcome to the last in the series of Care of the High-Risk Newborn. This is part 7 and will address intraventricular hemorrhage. You should be fairly familiar with this because it was also included in the neuro content. In a preterm baby, due to the fragility of their vasculature, they are more vulnerable to vessel rupture and hemorrhages. If they're less than 30 weeks gestation, they have the highest risk. An infant who suffers from an intracranial hemorrhage has a very high risk of having a bad outcome. 40% of these include an intraventricular hemorrhage, and only 20 mLs is considered to be a volume that's enough to kill a baby. They grade intraventricular hemorrhages on a scale of 1 to 4. So the 1 is the least amount of bleeding versus a 4. I believe your textbook only goes up to a level of 3. So a grade 1 and 2 is a small amount of bleeding, and usually we're not even going to worry about it. We just want to make sure the kid doesn't keep bleeding, but the outcome isn't going to be too bad. The grades 3 and 4, of course, have more severe bleeding, and we may end up having neurological insults that can remain permanent. The child may also develop hydrocephalus. When there is a bleed, there's also surrounding edema, and you know that's going to increase intracranial pressure, and that whole mechanism gets rolling, and it can lead to death of the brain cells. Blood clots also block the flow of the CSF, and that's what ends up leading to the hydrocephalus. As a result, this baby may end up needing a VP shunt. Most of these babies that end up with an IVH have them discovered by an ultrasound of the head. If necessary, the baby may end up getting a CT or an MRI, but most of the time these ultrasounds are pretty good at detecting it. And so these ultrasounds are done routinely on these babies, and they start at about day 7. Signs and symptoms of an intraventricular hemorrhage include changes in their vital signs, and of course their behavior is going to change. This baby doesn't wake up as frequently. If they had been feeding, they're not sucking as strongly as they were in the past, and those primitive reflexes are going to be decreased. The baby may end up with apneic spells, bradycardia, and then a desaturation. So you need to assess for the signs of increased intracranial pressure: the bulging head, increase in head circumference, bulging fontanelle, the dilated scalp vessels, those same things you learned in the neural content. For these babies, we want to try and get the bleeding stopped. Actually, it's not the only way we're going to get the bleeding stopped is to manage whatever the condition was that caused the bleeding to begin with. Some of them just have a spontaneous bleed. The hydrocephalus is going to be treated with the VP shunt, but they may have a temporary ventriculostomy until the baby is stable enough to take to the operating room. Once we know that this child has suffered from an IVH, then what we want to do is support their development as much as possible so that they have the best outcome. And here's an example of a baby who was supported. You see him up above. He's preterm. He's got very shiny, thin skin. He had a grade 4 intraventricular hemorrhage. He was born at 25 weeks gestation. He was only a foot long and didn't even weigh 2 pounds. He became septic. He suffered from a cardiac arrest. He was resuscitated. He ended up having a post-hemorrhagic hydrocephalus and needed a shunt. But look at him. He survived. He has a normal-looking head. He looks like he is moving. He's responsive. Of course, we don't know what kind of problems he may have when he goes to school, but all in all, looks like a pretty good outcome. So if we take care of these children, if we look for all the things that they are at risk for, we catch them early and we intervene, we have a pretty decent outcome. And eventually we get them all dressed up and we get to send them home with the parents. And this ends the lecture series on care of the high-risk newborn.